Thank you for joining this virtual symposium to discuss COVID-19 and communities of color. Our speakers are Dr. Catherine Womack, Professor of Philosophy, Philosophy Department, BSU. Her theme is Public Healthcare Ethics Amid COVID-19. Dr. Diana Fox, Professor and Chairperson of Anthropology Department. Her topic is Gender, Violence, and Environment. Dr. Danielle Lombo, Associate Professor of Economics Department, BSU. His theme is African Americans, Economic and Health Disparities. Dr. Joyce Ryan Anderson, Professor and Coordinator of Ethic and Indigenous Studies at Bridgewater State University. Her theme is Endangering the Health of Indigenous Reservations. And Dr. Louis Peretz, Director of the Office of Institutional Diversity at Bridgewater State University. His topic is Health Vulnerability of Latino. Thank you so much for that on behalf of the Minnock Institute for Global Engagement and Global Programs, and also the community, Bridgewater State University and our students. And so we would like to start with the first presenters. I think Kathy, right? You ready? So here we go, my friend Kathy.
Okay, so I'm going to share, give me a thumbs up if you can hear me.
Yes.
So, okay, good, excellent. All right, I'm gonna share my screen now. And here we go. So can people see the screen? Okay, great. So I'm gonna start. Tell me when I'm at 10. I've got a stopwatch, I've got my phone going. Okay. All right, so look, Jabbar, thank you so much for inviting me. And thank you to everybody who's a panelist and a participant. So I'm going to just sort of introduce the issues of social determinants of health and public health equity to set the stage for my fellow panelists to speak about the effects on particular communities. I have my email address at the end of my slides, so I'm happy to give my slides to you. I'm also happy to give you the sources of the slides. So I have PDFs because they've got lots of data on them. One final thing is that some of these slides are from an American Public Health Association meeting webinar on health equity. So you'll see the ones with APHA on them. So I decided not to reinvent the wheel on this. Okay, so first, a short primer on the social determinants of health. I violate PowerPoint rules by having lots of data on my slides, but I'm not going to read it. So what does the World Health Organization say social determinants of health are? The social determinants of health are the circumstances in which we live and work and grow. And in fact, these external circumstances play a very large role in sort of our health outcomes, sort of what sort of susceptibilities we have, what sort of diseases we are likely to get, both communicable and non-communicable diseases, and what our chances are of becoming disabled or dying from them. And we can see in the work of thousands of researchers that there are very clearly delineated health disparities that are determined by race, ethnicity, income, and all sorts of other things. Okay, so I have the big list, which is a sample of social determinants of health. In short, access to education, employment, living wage, access to healthy food, food security, also access to pollution-free and crime-free areas for breathing and moving are also extremely important to health outcomes. throughout the life trajectory. In addition, there are lots of social factors, such as levels of discrimination, racism, very unsatisfactory contact with local and other sorts of government officials, linguistic access, levels of incarceration within the communities, and also access to technology. All of these sorts of factors influence our health and well-being. Now, moving to Massachusetts, I've pulled a little bit of data. So, and none of this is any news to anybody here today. So we find unemployment rates for African-American and Black males and females were twice those of their white counterparts. This is especially difficult in lower age cohorts, sort of 20 to 34, the unemployment rates are more than double. So for African Americans, for young African Americans, than they are for young whites, and almost double for Latino Hispanics. And of course, this is all against a backdrop of gendered income inequality. So we see this, some data about income. Here's some data about access to healthcare. In Massachusetts, shockingly, in a survey, 88.9% of people reported that they have a healthcare provider. So that's huge. That's one of the highest in the nation. And 75% of the respondents said they'd had a checkup in the last year. However, that's compared to white respondents, Black and Hispanic Latino respondents are much more likely to rate their health as poor or fair, or uninsured or underinsured. Being underinsured is has in some ways more pitfalls than being uninsured, because you're forced into co-pays and deductibles, and so this results in lack of access to healthcare. Again, this is all against a backdrop of a very low supply of accessible and linguistically and culturally appropriate clinicians. So people have linguistic barriers, people have logistical barriers, there just aren't hospitals and healthcare providers in their neighborhoods. All right, so I have loads more demographic data if you're interested in sources. Turning to COVID-19, Jabbar pointed out, and here is a graph to show you, this is from today, that when we take a look at the number of cases of COVID-19 reported in Massachusetts, we only have race or ethnicity data for 44% of the cases. So people are supposed to report the cases, but somehow they haven't gotten logged in. This is the case in many states. Some states, as he pointed out, are actually reporting data, but there's a real lag. So we don't know in Massachusetts, other than sort of anecdotally or very locally, sort of what health disparities and health inequities, what sorts of effects those are having with respect to COVID-19. But we know from cases in Atlanta and in New Orleans and in Detroit that in particular African Americans are accounting for a very large percentage of the cases, and in particular the hospitalizations and deaths in numbers that are double to triple their prevalence in the population. Okay, now I'm going to turn to some talking a little bit about COVID-19 testing. And this is from the APHA Equity. You'll have to excuse me, I have to sneeze. It's allergies. I should have muted myself, oops. Okay. I've done it, so you don't have to worry about this happening to you. All right, look, so in order to get a handle on the COVID pandemic, we need to do testing, and we need to test loads of people, loads of times. But what are some of the problems? Well, first of all, we don't have enough tests, although in Massachusetts, we sort of do. But, you know, the testing isn't job or risk-based, right? So it seems to be symptom and exposure-based. And lots of people do not know that the symptoms that they have are symptoms of COVID, right? Another thing is testing times are not aligned with frontline job off hours. So people who work in service, you know, who work at grocery stores and do other sorts of, you know, other sorts of hourly wage jobs, they may not have access. Also, our paid sick leave is still inadequate in Massachusetts. It's better than lots of places, but it's still a problem. Lots of people do not have a primary care provider. So also there seem to be some cases of racial and ethnic bias in testing. We can talk about that later. With respect to share access, a lot of the testing locations are not in minority communities. Furthermore, the ones that are in other communities tend to be drive-through. Not everybody has a car, right? So there are legitimate sort of public health safety issues with respect to walking up, thank you, yes, with respect to walk-in testing, but these are things that can be dealt with, right? Again, so there seem to be gatekeepers for testing, and a lot of them are primary care providers, some of them are employers, but naturally these are not actually getting out to the people who need the information. So also there are issues about fear of discovery of being, about testing positive, because people with, you know, people who have lower incomes have much less of a social safety net, and also are, you know, may have insecure housing, may have insecure labor. And so there are lots of fears about what this information about being positive will do to their very precarious financial situation. So I'll keep moving. Jabbar, I want to spend 2 more minutes, if I may, on this Los Angeles antibody study.
Sure.
Okay, so public health people did an antibody study. So they did, it's not a COVID, it's not the PCR test, it's the antibody test. So they did 800 participants and did a rapid antibody test. Test has 90 to 95% accuracy rate, which by the way is not great. So lots of false positives and negatives. So what they found was about 4% of the adult population was antibody positive. With the error rate, we're talking between 3 and 6%. This is way higher than we expected. But here, look at the demographics. So African Americans and men were most likely to test positive. So in the sample, 6%, you know, of the positive people were men, 2% were women, but 7% were African Americans, 6% white, 2.5% Latinos. So we don't know, you know, whether this means, whether this sample about this antigen sample test determines that there are particular racial susceptibilities for COVID-19. We don't know, but we need to find this out. Okay, let's see. So we need to engage in some targeted actions to increase access to testing, and which includes education and communication and listening, right? And to find trusted people in the communities to be messengers and to be listeners. I'm not going to go through these slides, but they're very nice. Health equity means a shift in focus, right? We need to think in terms of racism, not race. We need to think in terms of social and economic factors, not genetics, and environment and environmental conditions, not just behaviors. Again, you're welcome to have these slides and the sources. So thank you very much. And don't forget to wear your mask.
Yeah, thank you so much. You know, it's really important that we in the United States should be proactive rather than reactive. And unfortunately, we always do these things in reactively. And I think has to be changed because it's unacceptable. With that, we'll go to our friend Diana Fox, who's going to talk about exactly gender, violence, and environments. Diana.
Hi, everybody. Thank you, Jabbar and Catherine, for laying that framework and foundation. I have to apologize because I do not have beautiful slides. It's been a little bit of a crazy time juggling lots of things. So I pulled together some notes and some ideas I've written them out. So I'm going to just go through them, and I'm going to start by talking a little bit about the kind of crisis that COVID-19 is. I'm going to focus a little bit on the gender issues, not only in the United States, but globally. Then I'm going to explore the environmental issues surrounding COVID-19, and then perhaps, if I have a moment, to try to pull them together and show how they intersect. As Catherine demonstrated and Jabbar in his comments, COVID-19 is a manifold crisis. It's a crisis of inequity as a public health crisis, it's an economic crisis, and it's a crisis of the environment. Focusing on women, women in many parts of the world are at particular risk because they are responsible for securing household food. Their risks are increased from going to shops and open markets, coming into contact with a greater number of people and therefore exposing them to the virus. In the global South, a significant number of women work in the informal economy. These are numbers that are invisible, that are not being counted. So we don't really fully know globally what the real numbers are, or what percentage of people from different gender groups are dying. So these women in the informal economy work in agriculture, they're domestic workers, they're vendors on the streets, often with any access to social protection. Girls in particular are from the poorest populations in the world, and they are among the most vulnerable. With school closures, girls from these communities are at higher risk of increased gender-based violence, early marriage, and higher rates of child pregnancy. Their futures are really endangered. Moving on to other points, there's limited access to critical sexual and reproductive health services, and this has created barriers to organizations that respond to gender-based violence around the world. Many of the issues that the global COVID-19 pandemic is exacerbating have long been pointed out by feminists and women's studies researchers and activists, and they're right in front of us. Around the world, the impact on women is multiple. There are many intersecting dimensions of violence, exclusion, and discrimination that permeate their everyday life, and those are coming to the fore in this pandemic. The most marginalized communities are hit the hardest across the global North and the global South. And I think that it's really important that we're talking about this because academia and academics have a central role to play in sharing and identifying these issues and then bringing them to the attention of policymakers. It's a duty of academics to do so. Let's look briefly at women's labor in the United States. Women are at the helm of fighting COVID-19. It's not just that women make up 91% of nurses, 74% of healthcare workers, and almost 62% of pharmaceutical professions. Having nearly half of the world's children home from school means that many mothers are trying to teach, caretake, and manage their workloads simultaneously. What's particularly interesting, though, is that because of so many women in the workforce, there's potentially a gender role shift in the United States that is unfolding. While women may be enduring the worst of the crisis at present in terms of their interface with the public sector, this might lead to male caretakers becoming more normal in the home. As of this January, women held more positions in the US workforce than men. They also had more college degrees, but men were still paid more per hour. As The Atlantic has reported, women still did most of the family's chores, as well as a greater percentage of childcare. While American men are doing more, 3 times as much childcare as in 1965, for example, at 8 hours per week, that's not the same thing as doing enough. Women spend 14 hours a week on household chores. But this crisis may be leading to some changes. Businesses, as we're seeing, are rapidly adopting flexible work arrangements, things that have been pushed for a long time by political progressives. We'll see if they are sustained. Also, there are many fathers who are now having to take primary responsibility for childcare, and perhaps over time, this may erode social norms that currently lead to the lopsided distribution of the division of labor in housework and in childcare. Globally, in the labor force, in addition to the factors that I pointed out already in terms of women working in healthcare, women working in the informal economy, women are also working in greater numbers as factory workers. And for example, in Haiti, in Myanmar, in Pakistan, where there are many garment factories, women are working in close quarters where there isn't adequate ventilation. So those are just a few of the examples of the kinds of conditions that women are facing, and these are also linked to the great inequality of late capitalism. We know, turning to violence now, that lockdowns and quarantines are essential to suppressing this virus, but they also can trap women and children and men and transgendered people, but the largest percentage of people who are abused in domestic violence situations are women, and they can trap women in these situations with abusive partners. The UN Secretary General, Antonio Guterres, made a recent plea about this, calling attention to this crisis in violence against women and children, and girls in particular. Over the last weeks, as economic and social pressures and fears have grown, we've seen this really taking a horrifying global surge. In some countries, the number of women calling support services have doubled. In other examples, the calls have gone down, but this is not a positive thing. This is because women are unable to find opportunities to call domestic violence hotlines without being observed by their abusers and then further abused. As well, local support groups are paralyzed or short of funds. Some domestic violence shelters are closed while others are full, also keeping women in close quarters. And governments must address violence against women as a key part of their national response plans. This means increasing investments in online services and civil society organizations, making sure judicial systems continue to prosecute abusers, setting up emergency warning systems in pharmacies and groceries, places where women go as procurers of resources for households, declaring shelters as essential services, creating safe ways for women to seek support without alerting their abusers. Women's rights and freedoms are absolutely integral for strong, resilient societies. Women from the global south and marginalized communities in the global north have coordinated and identified these variables through an organization called the Feminist Alliance for Rights, and they've called for a feminist response to the COVID-19 pandemic. They're lobbying governments to include some of the protections that I just identified for the most vulnerable. Moving on to the environment now, I want to call attention to the foundations of this crisis and what we have to look toward in the future for future crises of this nature. The Center for Biological Diversity and other environmental groups have underscored the links among global warming, infringement on wildlife habitats, illegal wildlife trade, and the spread of infectious diseases. The kinds of findings that the Intergovernmental Panel on Climate Change report detail what efforts are needed to limit global warming to 1.5 degrees Celsius. Without doing so, rising temperatures will exacerbate certain health problems, existing health problems that have socio-cultural determinants, such as asthma and kidney problems and other kinds of lung diseases that make certain populations more likely to get ill with rising temperatures. What also happens with rising temperatures is that, and these infringement on wildlife populations, is that there's an increasing spread of zoonotic diseases spreading between animals and humans, such as the COVID-19 virus, believed to have originated in bats before being transferred to humans via scaly animals like pangolins. As the world population growth continues to rise and natural habitats are encroached upon and destroyed, removing valuable carbon sinks like rainforests, but creating environments in which zoonotic disease carriers like bats thrive, we face a future crisis. So we have to address climate change. The second point I want to make about the environment is that the Trump administration is using this crisis to undermine environmental protections, doing exactly the opposite of what needs to be done to ensure the constraint of these diseases. Over the past weeks, as this crisis has developed, we've seen rollbacks in environmental protections of air quality and water quality. We have seen the Trump administration making efforts to gut the National Environmental Protection Policy Act. These are all 1970s Nixon era environmental laws that provide protections for, and are particularly important in impoverished communities where we see environmental injustice and environmental racism, toxic waste sites, combined with increasing permit to pollute, just exacerbates the kinds of health risks that poor people and people of color are facing. Of course, poor women of color are living in these communities, and therefore, combined with the high rates of domestic violence that I was talking about before, put these groups in particular risk when we look at the intersection of gender and environmental issues. They are tied together. I'll just sum it up right there. Thank you.
Thank you, Diana. So it's very clear that the early data showed us that the COVID-19 has already impacted communities of color. Joyce, it's your floor now.
Okay. Winnikisak, I will start by acknowledging the Wampanoag peoples upon whose land Bridgewater sits. And it's important to recognize and acknowledge, especially this day as the Mashpee are fighting for their land and trust. And it is up to all of us to acknowledge and act to support Indigenous peoples as we inhabit these lands. So for tens of thousands of years, Indigenous peoples have lived on these lands. And as contact came, so also did disease. The years between 1616 and 1619 became known as the Great Dying, and it was followed by several other epidemics. New studies indicate that this early disease was probably leptospirosis. But Cotton Mather wrote of these times, quote, "These woods were almost cleared of those pernicious creatures to make room for better growth," close quote. We also know in 1763, Sir Geoffrey Amherst suggested sending blankets infected with smallpox among the different tribes of the Indians, and to, quote, "use every strategy in our power to reduce them," close quote. I begin with this brief history because it's not surprising that the current pandemic of COVID-19, that Indigenous peoples are among our most vulnerable populations. Colonization took away land, took away lifeways, foodways, sovereignty, and took away the overall health of Indigenous peoples. While the CDC and Native nations have issued guidelines to prevent the spread, the advice to buy 2 weeks of groceries, to work from home, to wash one's hands with soap and water are difficult for many to achieve. Native American reservations are among the poorest communities in the United States. And with this poverty comes many inequities, and the health disparities rise among them. Heart disease, tuberculosis, and diabetes are at rates much higher than other groups. Death from diabetes are 189% higher than other races, and tuberculosis is up to 600 times as high. Life expectancy is about 5.5 years less than all other US races, and 28.6% under the age of 65 have no health insurance. 17.4% of all Indigenous populations are in poor health. The poverty rate ranges between between 25 and 40%, though I know Pine Ridge Indian Reservation, the poverty rate is about 80%. There is also food insecurity and substandard housing, which is overcrowded as multiple generations live together. And so the two reservations that I'm going to speak more in detail about are the Navajo and Pine Ridge. So of the 244,000 people on the Navajo reservation, 35 to 40% have no running water. The wells and the springs there are contaminated by the uranium mines, which was also a government intervention there. Pine Ridge Reservation, which is about the size of Connecticut, has only 5 ambulances and 1 hospital, and thus the distance to travel to get medical help or to have medical come to you is sometimes impossible. Indian Health Services, or IHS, has always been a fragile system. Of the 46 hospitals managed by IHS, there were only 71 ventilators and 33 fewer ICU beds. For the 50,000 Oglala Lakota, there are 24 test kits, 6 ventilators, and 4 beds available for isolation or quarantine. The Navajo Nation reports having about 220 beds, and they have, as I said, over 244,000 people. The average spend on IHS services for a person is $3,332 a year, which is 3 times lower than the federal government spends on a person nationwide. And I can give you those statistics. Even a prison inmate gets $8,602 per year spent. As of Thursday, April 23rd, there were 1,360 cases of COVID-19 and 52 deaths on the Navajo Nation reservation. That's the 3rd highest rate of infection next to New York and New Jersey. At this point, Pine Ridge has only had 1 case, and that non-native person was banished from the reservation and went to Rapid City over 100 miles away. Pine Ridge has a lockdown in place, and you cannot travel on the reservation unless you have an essential worker permit with you. And almost no one is allowed onto the reservation now. These may seem like extreme measures. However, given the number of elderly and those with comorbid conditions, COVID-19 could spread faster than a prairie fire through the population. And the fear of losing elders is real as they hold the cultural knowledge. While the CARES Act has set aside $8 billion for the 574 federally recognized tribal nations, there is currently a fight over how to distribute that money. This is not something unusual for the federal government when it comes to Indigenous people, as Indian Health Services often runs out of money by June of any fiscal year. There is a documentary that's called Don't Get Sick After June, which our library has, because everyone knows that there's no money to treat you when it gets to that point. But as far as the argument that's going on, because the money could go to other tribal entities, which are not the tribes themselves, but just organizations that exist near the reservations, the Navajo Nation and 10 other Native nations have currently filed suit against the US Treasury. And although there are only 300 plus acres at stake for the Mashpee Wampanoag, the recent decision on March 27th to disestablish the reservation or land in trust is another example about how the federal government has treated Native peoples. The irony is not lost that this happens both during a pandemic and in the year 2020, 400 years after the Wampanoag helped save Plymouth Colony during the first winter of their 1620 landing. Disestablishing their land and trust takes away sovereignty from the people at a time when the COVID-19 pandemic is surging in Massachusetts, and they are struggling to help keep tribal members on their health services and food programs. As is custom, tribal natives have stepped in to help one another. The Cherokee Nation, for example, has sent PPE to the Navajo Nation, and the Eastern Band of Cherokees also just authorized $100,000 to be donated there. Indigenous peoples always take care of each other, and they have warned about the ways in which consumption and greed have changed the planet. We cannot ignore some of these diseases arise, as Diana said, as forests are cut down, and when the mother who holds us all on her back is abused. Native peoples have fought the onslaught of colonialism that has demeaned them as human beings, and that aftermath still neglects them. The treatment that they are receiving now is no different. It is always the vulnerable who suffer. Indigenous peoples have been here before and still have survived. And even when the situation is dire, their resilience is strong. Katapatash.
Thank you so much. With that, I would like to go to my friend, Luis Contreras, to talk about health vulnerability of Latinos.
I'm still muted. All right, can everyone hear me?
Yes.
All right, hey everyone. Alrighty then, let me share my screen. Give me one sec. All right, can everyone see it? Okay, alrighty
Yes.
then. All right, let me. All right, give me one second. Alrighty then, so I just wanted to focus, and I'm being all intentional with the picture here of the avocado, especially because of the workforce that this particular population brings to the nation. And I want to focus on this idea of essential bodies and why this virus is affecting populations of color. And I cannot speak of just the Latinx experience without speaking of other communities of color, because there are so many similarities in between them in lifestyle and culture. And I just cannot speak of one without the other, or multiple, or offering other examples. So I just want to offer a couple of facts that I have found in different articles, just to give us an idea of where we stand with this virus, right? So as of right now, we know that about 6,000 Latinx people are known to have lost their lives to COVID-19 through April 23rd, actually. And then compared to almost 2,000 deaths compared to just 3 days earlier. And for each 100,000 Americans of their respective group, about 11 Latinx have died from COVID-19, a mortality rate slightly above Asians, which are 10, and whites to 9, but well below Blacks, 26. Latinx are nearly 2.5 times less likely to die as Black Americans from the virus. In 5 states, which significant Latinx populations such as New York, New Jersey, Connecticut, Rhode Island, and Maryland, as well as Washington, D.C., the mortality rates for Latinx residents exceed the national mortality rate of 11 deaths per 100,000. Most dramatically in New York State, right? So as we also have this conversation about how this virus is affecting different communities, we also have to pay attention to location, right? And life in New York City is very different than life in Brockton, per se, right? So there's different factors to take into consideration. In New York, Latinx comprise 19% of the population, but have suffered 26% of deaths. At the time of this writing, nearly 4,000 Latinx had died in New York, which has experienced the highest overall rate of any state, death rate of any state. In 26 states in Washington, D.C., Latinx have a mortality advantage, dying less often than their population would suggest. I guess that's a good thing. They're most underrepresented, dying far less likely than their population share in Texas and Arizona. When we combine data across all 35 states, reporting data in Washington, D.C., Latinx are dying from COVID-19 slightly below their share of the population, 19%. They have suffered 16% of deaths in America where race or ethnicity is known. This shows the outsized influence of the loss of Latinx lives in New York State alone. Now I want to focus a little bit on facts that correspond to the politics of existing, of belonging, right? The politics of representation and citizenship. So just to give you statistics about population rates compared to death rates, right? So in Utah, Latinx are being infected and hospitalized at 3 times the rate of white people, whereas Latinx make up 14% of the state's population, 29% of the patients who tested positive for COVID-19 in the state identified as Latinx. In Oregon, Latinx accounted for 22% of coronavirus cases where demographic information was available. Latinx make up 13% of Oregon's population. In New Jersey, Latinx make up 19% of the population, but nearly 30% of the COVID-19 patients in that state identified as Hispanic. In Washington State, 25% of those infected are Latinx, while they make up only 13% of the state's total population. A couple of other facts just to put this into context and then focus a little bit into the specifics as to why Latinx people might be at the epicenter of the virus contagion rate. So 1 in 3 Latinx live in poverty. That's as a national context. 1 in 2 Latinx families are low income. Nearly 60% of Latinx earn less than $15 an hour versus 39% of full-time workers overall. This is a town in Jersey. So in Hayes, New Jersey, Latinx brings 60% of what white families earn. Only 16.2% of Latinx can work from home, and the far lowest percentage among African Americans, almost 20%, white Americans at 30%, and Asian Americans at 37%, says the Economic Policy Institute. And then I also want to focus on specific issues that may, that is not exclusive just to the Latinx experience, but to other communities of color or any communities that may have immigrant families. So in this case, for the Latino population, there's the case of transnational families. So it's not just the issues happening in the global north. This might also be affecting, actually it is affecting most families in the global south too. So there's almost this understanding of living in between borders and dealing with the border too, right? And I'm sorry, and dealing with with COVID-19. And also another layer to this issue is immigration status. Some of the reports or some of the numbers that we know today are intelligent estimates because we don't have enough in reporting, we don't have enough data to suggest specific numbers. And there is fear in that a lot of the people that may be passing away may have undocumented status. And then again, unpacking the multiple realities, right, of people that may be living in a large city versus life in Brockton, right? All of those things do affect populations. And then with Black Americans, I just want to mention this too. The CDC found that 33% of people who've been hospitalized with COVID-19 are African American, yet only 13% of the US population is African American. So again, in comparing that data, there's so many similarities of experience, right? Which leads us to think of the social stressors, right? The social stressors that some of these communities have to deal with. Living conditions, for example, right? Members of racial and ethnic minorities may be more likely to live in densely populated areas because of institutional racism, right? Things that were mentioned in previous presentations. So segregation from home, racial, ethnic households. There is also working circumstances, right? Most of Latinx workers are critical workers, essential workers, right? They are at the risk of infection at a greater rate because they are in the spaces where their presence is required, where their work is required. A couple more statistical data here. Nearly a quarter of employed Hispanic and Black or African-American workers are employed in service industry jobs compared to 16% of non-Hispanic whites. Hispanic workers account for 17% of total employment, but constitute 53% of agricultural workers. So going back to the avocado picture at the beginning, right? We are still eating, we are still functioning as a nation, but where is this food coming from, right? People that are invisible, people that we don't have to think about because they don't account for anything necessarily. But in times of a pandemic, right? These bodies, right, these disposable bodies become ever more essential because of their worth, right? And because social distancing is also a privilege. So we also have to acknowledge that. Another thing is the underlying health conditions and lower access to care. And this is an issue for many communities of color. Not having health insurance. I mean, things that were mentioned before. I don't want to be redundant with the information, but again, inequality, right? That is what's being exposed most with this pandemic, and which leads us to think about structural poverty, right? Essentially, it's exposing all the ugly of our society, right? We knew that these issues existed, but now what are we going to do post-pandemic, right? And I cannot stop thinking about students, right? And how this is going to affect specific student populations. So in the case of the Latinx student population, right? When this is all over, how are we going to operate for them, right? We have to think about achievement gaps, right? Opportunity gap, learning gaps, learning loss, right? Because many of them are able to escape realities by living on campus, and now that they're working from home, taking 5 online classes or whatever the case might be, and having to now take care of the sibling or having to translate for the parent. There's so many other realities that are part of the reality for many of these people that we have to keep that into consideration, right? And then re-engaging them into the college experience, and then financial needs, because we know that this is going to be affecting our finances, not just in the immediate future, but perhaps for the next few years. So I wanted to provide a collection of factual information that relates to the Latinx experience to expose what's happening, and to also remind the community of realities that these people have to go through that are not necessarily in our daily purview, because we don't have to think about it. But this pandemic is giving us the chance to incorporate these voices into the conversation. So I really appreciate this. And that's all I got.
Thank you. You got a lot. Thank you so much, presenters, all of you, my friends. So just to add, nearly a quarter of Blacks and Hispanic, because you mentioned some data, 24%, that's Blacks and Hispanic, are employed in services industries compared to 16% of whites. You're talking about grocery stores, you're talking about gas stations, you talk about, of course, even hospitals. You talk about, you know, I mean, all this, of course, they will be subject to this novel virus in terms of the infection. And so, you know, we found now through the really in-depth data and analysis, though you had already, all of you, 15 minutes or even less, we will conclude with this, then we'll open it for discussion. Communities of color are at increased risk for experiencing serious illness if they become infected with coronavirus due to higher rates of certain underlying health condition compared to whites. Communities of color will, and they are really, facing increased challenges across accessing COVID-19 related testing, as you mentioned, and treatment, since they are more likely to be uninsured, and even some of them undocumented due to poor immigration policies. I would like to open the discussion, and you can be on camera, you can be only phone.
I'd have to unmute your microphone when you speak because I had muted a couple people to make sure there was no different sound.
Sabrina. Okay, yes.
Jabbar. The main thing I want to do is thank my colleagues who have shared their time and their expertise and their heart today. This is a vitally important issue. As I think about higher ed generally, not Bridgewater, as I think about higher ed generally, the concern I have is that many campuses may lapse into a stance of this is an issue that affects all of us, which it does, and revert back to a cookie cutter approach that privileges hegemony and deepens inequities. At Bridgewater, I'm confident that that is not occurring, will not occur through the leadership of our speakers and many others on the call, so thank you. Speaking about Bridgewater specifically, I think what we're talking about our students is exactly what I'm thinking, which is what we know from our own experiences from institutional data is that typically, not always, but typically those experiencing educational gaps are actually educational equity gaps. We know, for example, our white students retain persistent graduate at far higher rates than our students of color. Even though we are a national leader in closing gaps, we still have a very large gap at Bridgewater. And so I will be posing the questions that are keeping me up at night, and I'm sure all of you, not sharing any answers. But in addition to the very fine work that is already occurring in the classrooms and now this remote delivery model, with the very fine work that is happening through an array of curricular and co-curricular interventions, what else can we do as a community to take next steps so that our educational equity gaps don't deepen? And what, if anything, can we do to deepen our community ethos, which is already amazingly strong, so that we can move forward on behalf of our students? These aren't any answers, but these are the questions I'm posing. And today's panel and conversation has been very helpful in informing my thinking about potential next steps as it relates to my work at the university. And what I'll say as a person who enjoys white privilege is it is another call to action for me as a person and a professional to think, what else can I do to utilize this privilege that I did not earn on behalf of racial equity and justice? So the main comments I want to share, Jabbar, is thank you.
Thank you, Sabrina. So Diana, Joyce, Catherine, Lois, and yeah, the four of you, you can come up with this answer. Diana? You hear me?
Hi, yeah. I suppose as I'm thinking about all these different angles that everyone has presented regarding how the pandemic is affecting different communities, and thinking about the kind of non-cookie cutter response and approach that Bridgewater needs to take. I think that we need information, and we have to think about how we can gather that information. I know that many students that I am in touch with through my classes and through emails and even texting now have shared their stories with me. quite a few of my students have been impacted directly through sick family members, through mothers, sisters, aunts, who are daughters who are working as nurses, for example, who have family members who have fallen ill. So we have to think about how we can gather the data to understand the impact that this has had across our campus for not only our students, but staff, faculty, administrators. And I don't know, now is not the time for any kind of survey because people are scrambling to finish with the semester. But at some point, I think we have to create a data gathering tool to assess and evaluate the impact on people's lives financially, in terms of their health and well-being, psychologically, in order to know how to go forward. And this is the foundation of social science, is that you cannot make recommendations without having the data. So we can look at, we know what we know the demographics of our campus, and so we can make some educated guesses. We can hypothesize about the impact that this is having, but we also need to have individual stories and concrete data.
Thank you, Diana. Catherine?
Yes, thank you, Sabrina and Diana. I just wanted to add one thing, and it's small, but I think kind of important, which is this. From my own experience, I am feeling connected to and very grateful to my students for hanging in there in the ways that they can, through the various modes. So I've been teaching synchronously. I do, 12 times as much student email as I used to. I text students, I talk on the phone with them. We're all doing this. But this is the result of being able to leverage our in-person relationships that we had with them in the beginning of the term.
Yes.
So we may not have that going forward in the fall. We don't know. I think it's a coin flip, whether we're going to be able to connect with our students in person. And I'm very worried about sort of the effects on our students, in particular communities of color, because there's loads of data, about sort of, what do I want to say? Again, social determinants of that interfere with student engagement, and that, result in suppression of student abilities to perform and to endure and maintain over the term, right? So without this in-person connection, I think we're going to have some, I think communities of color, our students of color, are going to be disproportionately harmed. And it's a thing I'm worried about.
Thank you. We have, for the panelists, we have one question from one of our students. It says, I wonder if there are any statistics on child abuse with the school no longer a safe haven for many to escape a dangerous home. It seems likely that the danger of child abuse would increase. I also wonder that students, what a statistic of domestic abuse against men, it is something to investigate and find solution for. Probably Louis and Joyce, if you want to do anything on this. Yes.
So I know that this is a big concern on the reservation, because there is so much, there's just so much in general, but food security included, but there is a lot of child abuse on the reservations. And the school that we work most closely with is Red Cloud Indian School, and even there, where it's probably the school where they're having more contact with the students, there is that huge concern that the child abuse is just going to continue, and of course that for the students, the worry is that suicides will increase. So it's dismal news, but it's hard. I mean, that reservation again is the size of Connecticut, and so just the distance between place to place is a very difficult thing to manage.
Thank you. So any other questions from our incredible audience?
Can I just add something about
Yes,
the child
Diane.
abuse? In Massachusetts, the reports of child abuse have actually gone down by half, which is not a good thing. The reason for this are those that I had mentioned, that the social distancing is preventing many of the social workers and others working in the area of child abuse and domestic violence from doing their regular visits, the phone call from people who are populating those call centers. All of those places have fewer people working, and therefore there's less data that's being collected, and it's more difficult also for both for those who are abused to reach out and to report that abuse. So we really don't have accurate statistics now, and it's actually quite frightening. So I just wanted to just add that.
Yes, Louis, please go ahead.
I also wanted to mention that domestic abuse numbers have significantly increased worldwide. So this is a phenomenon not exclusive to just the United States, but it's a world issue now. And I also wonder how much that is going to impact mental health moving forward, in particular in some communities more than others, right? I mean, how this domestic abuse is going to affect the mental health of people. It's something to consider too.
Thank you. You can raise your hand. There's a little hand there, or you can just jump on. Okay, Winkai, yes, please. You use your mute. Open it. Yes. No.
Hi, I wanted to talk about a few things that haven't been covered so far. I think from a global perspective and also from the Asian American perspective, I think there have been a lot of reports about hate crimes against Chinese and Asian Americans because of the virus and the name calling and the labeling that were used to describe the origins of the crisis of the virus, and being called the Chinese virus, the Wuhan virus, or Kung flu, or things like that, all these terms. And San Francisco State University, the Asian American Studies Center, is collecting all the data about hate crimes in the country against Asian Americans. There have been reports of over 150 hate crimes across the country, and they're collecting the information all the time. And there have been reports of attacks in the subways and on the streets, and Chinese Americans being spit on and things like that. So I just want to call attention to that as well, because unlike these other situations of other communities of color, Asian Americans, especially the low-income Asian Americans, they are facing a double discrimination and disadvantage. They disadvantage because they lost their ethnic businesses. You know, a lot of people are not really going to Asian restaurants or other businesses. They also discriminated against them. So I think we need to also talk about both in terms of African Americans and Asian Americans being better brunt of the crisis in terms of the ratio of deaths for African Americans and the ratio of hate crimes for Asian Americans. Just a very quick second point from a global perspective. There have been reports by New York Times and a few other newspapers about how the disruption of the supply chain has affected the food supply for the world. And it ends up affecting a lot of countries in the global south and other parts of the world. There are a lot of countries that are facing food shortage right now because of COVID-19. So this is going to result in a lot of hunger and famine or other issues in the future. So I think this is being reported recently. So the impact of it on most of the populations in the world is going to be really huge for the months to come. So those are my 2 points that I wanted to add to it.
Excellent. Thank you for adding this to the conversation. Any other comments or questions, please? Yes.
May
Go
I?
ahead. Sabrina.
Thank you. Sorry, I'm learning my competencies. If I may go back a few moments to the conversation with Diana and Catherine. Diana, your point, which I full-heartedly agree to about we need to know more. This does not in any way rise up to a research study, but last week, Bridgewater used for the first time with all of our students a new piece of technology we have called AdmitHub. AdmitHub is a virtual bot, a chat bot. And so we reached out, we purchased it a few months ago, and it's been being used on the admissions side. Last week we started to use it. We were gonna start in the fall with our current students, but we started using it last week with our current students. And we did 3 campaigns, one for undergraduate students generally, one for continuing studies, and one for grad students. There's 3 different chat bots, language things a little bit differently, but reaching out and finding out how our students were doing generally, what they might need, how they were doing with remote learning, and then anything they might need around registration. So that does not rise up to the kind of in-depth information you're talking about, Diana, but it's a beginning to do in real time, reaching out to students who might need things. And then it's more detailed than is appropriate to get on the call because I don't want to take up too much time. But there's 7 or 8 specific outreach campaigns that are going on right now on the staff administrator side to students that we believe to be at greater risk at this time to support their success around economics, academics, etc. We all know on the staff administrator side that the heavy lifting and the magic for the student's success is in the classroom with faculty and librarians. But on our side, we're doing what we can to be of support with the non-academic things. If any of you would like to know about any of those campaigns, just be in touch.
Thank you. And, you know, I see our friend Angelo Parposo, so probably we can include also, we talk a little bit and shed light about our community, let's say in Brockton or in Boston, the Cape Verdean too, you know, I mean, this is, the community is also being actually impacted. Would you mind say a few things?
Yes. Thank you, Dr. Jabbar. Thank you, everyone. I really appreciate this event, the meeting that you put together. And before saying anything, I would like to ask if you could share with me all the slides that you presented, because I think those are very important information. But I just wanted to make just 2 comments. First one has to do with the very important points that was, at least I took as a summary from your presentations. First one is the social dimension of this issue. The other one is the role of the academy. I think this is really the time for the academy to step up in terms of, you know, bringing the discussions at the level that it should be taking at so many directions. So when we talk about the minorities and those issues, these are really serious problems that we are facing. And the next thing is the data. When we talk about the data, we can talk about the data in so many different dimensions also, but also today I would like to bring is the stories that I've been listening. Just to give you the information, Brockton is a hotspot. So it's the area that a lot of Cape Verdeans living. So far, we lost about 30 Cape Verdeans in Brockton. This number is close and sometimes higher than many states in the US. So this is a big issue. yesterday I participated in a large conversation in the Brockton City through the Zoom meeting. So the situation is really serious for the minority community. And so the discussion is on. You know, the emotional side of this is huge. I've been, you know, I have a kind of my ears are hurting because I've been on the phone for so many hours reaching out to different friends and families in the area that, you know, are, you know, difficult situations. So I think this is really the moment for us to think how we take this onwards and see what kind of the dialogues and the ways and the solutions that we need to bring for these communities. Because here in Brockton, just to finish up, is the Cambodians are the frontliners. So they are in the CVS shop, Walmarts, they are nurses, police officers, but also they are doctors. So I've been talking to doctors that are really facing serious times inside the hospitals. So again, thank you for putting this. I will keep connected with you to update you on necessary information as far as this community.
Thank you for your comments. Actually, this is a time, yes, to stand shoulder to shoulder with one another and also to reach out through whatever media we have, phone, social media, to our colleagues, our friends, our neighbors. Really, this is not like rhetoric. This is should be real. And our students, as all of us know, I mean, this is the opportunity for us to really move even closer by supporting them academically, culturally, economically, if they need. I ask students to do that. And, you know, one of our co-hosts, of course, my dear friend, Michelle, of course, Michelle, she hosted this from the technical side, but also I know she is very active in social media with the students. So, Michelle, would you mind to share some of your experience with our students and students of colors? Because you know, I saw some of them. I recognize some of the names. Actually, they are attending. Yes, go ahead.
Right. So I will say that I know that I'm working with a student who, you know, in response to what Wing Kai had just brought up about the attacks on Asian Americans. And Jabbar, as you know, I went to the program in China a couple of years ago with you and other people, and so that really makes me sad to see that outcome happening with all of this. I'm working with a student who is in my COM 299 class. They all made kind of use what you have videos about their experiences in quarantine, and this student is actually still at the BSU dorms because she did not go home to China. And so she made a video about her experience, sort of first worrying about her family back in China and now them more worrying about her being in America. And I think it's a really poignant video, and I'm hoping that we'll be able to post it on our social media and maybe it can be shared with others, because I think it really shows it from her experience, which is a human experience. You know, she did a beautiful job, and it shows the power, I think, of video to tell stories, you know, of documentary essentially. But I've really enjoyed listening to all of you. It's been very informative, and you know, it raises issues that some of which I had heard of or read about and thought of, but others that, you know, were new to me. So I really appreciate learning so much during this panel.
Thank you. Thank you. We have 5 minutes. Yes, Diana, please.
Hi, everybody. I guess I'm thinking about how to connect all of these different ideas and points. And as when Kai and others were talking about the populations that have not been mentioned, I also wanted to raise the discrimination against the Orthodox Jews in Brooklyn. And so what this really points out is that every single population that has been marginalized, that has been excluded, discriminated against, is targeted, is victimized in different ways. The recipient of violence and the kinds of historical stereotyping and name calling that are specific to particular populations, the kinds of attacks that are particular to populations that are derived from their historical experiences of marginalization in this country are coming to the surface. So the term people of color is a reductionist term. It's a homogenizing term. And so this conversation has pointed out the significance of intersectionality, looking at the intersections of gender, of ethnicity, of race, of religion, of financial status, of occupation. All of these things work together. And if we're going to use this discussion as a foundation to think about what kind of research needs to go forward at multiple levels, both macro level, how we are articulated in the global economy, the environmental issues, and all the multiple populations, and as well as micro levels, the stories that give substance and emotion to these larger issues, then I think we've really identified a starting point for how to go forward with this.
Catherine, yeah.
Yes, just a quick comment. Thank you, Diana. You're absolutely right. Intersectionality is everything when it comes to sort of taking a look at the different ways in which different subpopulations are marginalized, are vulnerable, and also the kinds of needs that they have. I'll just mention one more. I'm making a shameless plug. I write for a blog called Fit is a Feminist Issue. And on Sunday, I'll be blogging about how weight discrimination is entering into COVID-19. So there was a big story in the New York Times saying obesity is the #1 risk factor for hospitalizations and complications. No, it's not. Because if you go to the studies, it doesn't show it at all. And in that story, in that New York Times story, it was saying heavier patients are difficult to handle, right? So there are all kinds of sort of derogatory characterizations of all kinds of populations. So, weight stigma is one of the things that I happen to work on, and I'm a member, of that population. At any rate, back to Diana's point and my other colleagues' points, paying attention to the ways in which we, our students and community members, have intersectional identities is going to help us in figuring out the different ways to move forward to try to make this period one of less damage and more unity.
Thank you so much.
And
Thank
Michelle.
you so much.
Thank you.
Have a good
Jabbar.
night.
Thank you.
For organizing
So good